Coming up next on Primary Care, breast cancer screening. With higher death rates, Black women face greater risk.
So it's not that they're not getting their screening mammograms. It's just that, number one, the biology of the tumors sometimes are more aggressive.
Hello, I'm Dr. Lonnie Joe, and welcome to Primary Care, the show dedicated to improving the health of African Americans. Breast cancer is less common in Black women, but they are 40% more likely to die from it than white women. This is a serious issue. The problem is that Black women often don't get the same access to care or treatments. On today's show, we're going to talk about the urgent need for increased awareness of breast cancer screenings, the new screening recommendations, and how we can close the disparity gap. Joining us today is Dr. Annette Joe, who will share her insights and expertise on this important topic. Dr. Joe is Clinical Associate Professor of Radiology at the University of Michigan Medical School and a Fellow of the American College of Radiology. And in full disclosure, my wife, Dr. Joe, welcome to the show.
Thank you.
Dr. Joe, tell us why it is so important that we enhance, up our game, get our level elevated on why we need to do breast cancer screening, most importantly for Black women.
Okay. So screening for breast cancer is important for all women, okay? And what screening does is detect cancer at the earliest possible stage. So the goal is to find cancer when it's really, really small before it's clinically apparent. And so it can only be detected with screening before it possibly could spread to other parts of the body.
So what age should we in the community, especially in the primary care setting, what age should we be encouraging patients to start screening?
Okay. So it's been proven that starting screening at age 40 for average risk women and having a mammogram every year saves the most lives. So this is very important. Some high-risk patients should be screened even before 40. But for the average risk woman, they should be screened at age 40 and have a mammogram every single year. So women should be assessed when they are 25 to determine whether they should actually be screened before the age of 40. And so you would discuss whether they have any family history of breast cancer, mainly premenopausal and multiple family members with breast cancer, and also if they've had maybe a biopsy of the breast that shows any type of atypical cells. So those are things that would suggest that they need to be screened even before 40.
So there are special situations, especially family history, that would dictate that 40 is out the window. You need to get in and get assessed and also possibly get screened even before the age of 40.
Yes, if that's indicated.
So basically 40 is sort of like the rule of thumb. When do you get your mammogram? Starting at age 40. Yes. Does that change in terms of ethnicity at all?
No. Beginning at age 40 for the average risk woman, for everyone, is what's important. Some organizations have suggested that you can start screening at 45 or 50, but it's very important, especially for African American women, to start screening at least by the age of 40, because they have a tendency to develop more aggressive breast cancers, and so we want to try to catch them as soon as possible.
So all this noise that we heard in the press and in the literature a few years back saying that you can get a mammogram every other year, that was really just somebody's opinion, not very well thought out.
Yeah. So it may be okay for some women, but definitely not African American women, because the types of breast cancer that they sometimes get, the triple negative and inflammatory breast cancer, they grow really rapidly. And so if you skip a year and you have a triple negative breast cancer, it has a chance of getting really, really large before it's detected. And you don't want to wait until it's clinically evident before it's detected.
So the testing itself, the mammogram, tell us about it. What is it?
Okay.
Are there different types?
Okay, so a mammogram uses x-rays, just like if you got a chest x-ray or any other type of x-ray of a body part. But it's a very, very low dose radiation, okay, that we use for the x-rays. We do routinely 2 views of each breast, and that way we can see we try to see all of the breast tissue that's possible. And we do compress the breast. Some people say it's painful, but it's only for a very short period of time. And some women, if their breasts are tender certain times of the month, they can try to avoid that time of the month getting their mammogram. But it's not extremely painful. It may be a little tender. The breast may be tender when it's compressed. But it's only for just a few seconds, and then the compression is released. Okay? So what's important too is when a person comes to get a mammogram, that they follow the instructions, not to use deodorant before they come, and not to put lotion or anything on the breast. Some people think they can put on deodorant and nobody would know about it, but it can show up and look like calcifications on the mammogram.
It can give a suspicious finding on the test.
Yes, so calcifications can be a cause of cancer, can be a sign of cancer. And so if we see little particles on the mammogram, sometimes we're not sure if it's cancer or if it's just deodorant. So a lot of times the patients will have to come back to get extra views, and so it's really important that they follow the instructions, not to put any substances under the arm or on the breast before the mammogram.
So we just went through this unfortunate COVID craze in the world, not just this country but in the world, and we did have some issues surrounding women who would get the COVID vaccine and get a mammogram in close proximity. Tell us about that.
Okay. So any vaccine, not just COVID vaccine, any vaccine can cause the lymph nodes under the arm to become more prominent. And so if you have a mammogram right after the vaccine, sometimes the lymph nodes can look enlarged, and so we would ask the patients like which arm did they have the vaccine in, and initially we were calling all those patients back. But now we know, we're familiar with those changes, and so most of the time, we just attribute it to the vaccine.
So, in the primary care arena, what should the primary care physician know about breast cancer screening? And I mention this is because I've heard you do a lot of talks on this, and I've been in a lot of settings where there is this confusion about what should and should not happen. Baseline, what should primary care physicians be aware of in terms of advising their patients?
So number one, they should emphasize the importance of screening to their patients. And like we were saying, beginning mammograms annually, beginning at age 40 for the average risk woman is very, very important. And so sometimes a doctor may give a patient a request and they may just not even go get the study done.
That happens all the time.
Yes. And so to emphasize the importance of getting these screening mammograms. And so that's one thing. The other thing is to let the patients know that even if they get a mammogram that's normal, if they detect any changes in their breasts, to let you know so that you can get diagnostic images. A mammogram usually picks up cancers, but it's possible, especially like in a dense breast, or if a cancer is located out of the field of view of the mammogram, the patient may feel something the day after they had a normal mammogram. So it's important that they report that change, and they're sent for diagnostic imaging. They get special mammogram views and always an ultrasound also.
When it comes to disparities, why are we continuing to suffer? Well, we suffer with this across the board almost in any disease state, but why are black women less likely to be diagnosed early but die from breast cancer more than any other population?
So studies have been done that black women are screened at about the same rate as white women. So it's not that they're not getting their screening mammograms. It's just that, number one, the biology of the tumors sometimes are more aggressive, okay? And so if 25% of breast cancers in black women are triple negative, which are the...
That high, 25%?
Yes, 25%, whereas it's half that in white women, okay? So they often have a more aggressive cancer, and then the important thing is that once something is detected, they should act upon it, okay? So they can't take a year to go back to get, some diagnostic imaging. So if they get a screening mammogram and they're told they need to come back, they can't ignore that. They need to act upon it, get their diagnostic imaging. If something is detected that is suspicious, then they should not hesitate to get a biopsy done. And if a cancer is diagnosed, they should agree to whatever treatment that their doctor recommends.
But people are afraid of the C word. I mean, the cancer word, and we frighten them a lot of times, just like we do when we pick up our prescriptions from the drugstore. It says this medication is going to cause everything, and that kind of fear has to be dealt with, especially in this arena. We have family members who will not adhere to the guidelines in terms of screening, and because of fear. How do we address that in the black population, because it should not be a barrier to getting screened?
So I try to tell my patients that, when I have to tell them that it looks like they might have breast cancer, I have to let them know that it's a good thing that they came to get it diagnosed as early as possible. And even if it's at a later stage, because young women, when they're not being screened, their cancer may be large by the time it's detected, but still most people do well after a breast cancer diagnosis. So the smaller the cancer is, the less aggressive the treatment, extensive the treatment is that would take care of it. But even large cancers, they may need chemotherapy, radiation therapy, but most people do well even after cancer diagnosis, whether it's large or small.
Annette, I am always amazed at people who we find out that there's an issue with breast cancer and they don't know their family history. They know that I had an aunt who died, I'm not sure what they died from, or I'm not sure what happened with grandma, and it turns out that there are people in their family that, not necessarily first degree relatives, but close enough to say, boy, we should have known about that history. We were at a program in Ann Arbor, and I think people made the connections of 3 or 4 people in the same family that had breast cancer, and they didn't know. Why are we still struggling with that kind of issue, and does his family history play a role?
So family history is very important, and when someone's diagnosed with breast cancer, they should let their family know. Because if a person has a first-degree relative, which is a father, mother, brother, or sister with breast cancer, that increases their risk of developing breast cancer. And if they have multiple family members with breast cancer, that can put them at a higher risk also. And this is the situation where we were talking about earlier, where they may need to be screened before the age of 40. And not only be screened with a mammogram, but they may need MRI. And so the risk of developing breast cancer determines when you should be screened and with what different types of modalities.
When we start talking about screening, we get into the discussion of genetic markers. Tell us about BRCA1 and BRCA2 genetic markers.
Okay. So BRCA1 and BRCA2 markers, the gene is a gene mutation. So the BRCA genes, they normally suppress breast cancer. Like if there's a DNA that's damaged, the BRCA gene can repair that DNA. And when there's a BRCA mutation, then they don't function normally, and so it doesn't repair those abnormal genes, and so the breast cancers are more likely to be able to develop. So there's about a 60% chance of a person developing breast cancer in their lifetime if they have a BRCA gene mutation. And black women are more likely to have a BRCA gene mutation than white women.
So another first-degree relative in the family has breast cancer. Should we be pushing for genetic testing in that population?
No, not everyone. So if there are multiple family members with breast cancer, or family members who've had breast cancer at a very early age, then that's when it's important to get the BRCA testing.
What about other disease states or conditions like obesity, diabetes, hypertension, all of the usual things that we see? Do they have a effect on breast cancer or a predilection for breast cancer?
Okay, so obesity postmenopausal can increase the risk of breast cancer because the extra fat produces estrogen, and so most breast cancers are estrogen receptor positive. That means that the estrogen feeds the breast cancer and helps them grow, okay? And so that's why postmenopausal obesity can increase the risk of breast cancer. As far as hypertension and diabetes, it doesn't really increase the risk of breast cancer, but it can cause some signs on the mammogram that sometimes it can be confused with suspicious findings. Like diabetes can cause masses. It's called diabetic mastopathy, and it can look very suspicious on the mammogram and on the ultrasound. And but then when a biopsy is done, we can prove that it's benign. As far as hypertension, it can cause vascular calcifications, and when those first start to form, sometimes it may look like little cancer starting to form. And so
in a high blood pressure patient, on medication or without medication, those kinds of calcifications can form?
Yes, and it's in the vessels. They're in the blood vessels. So when they first start to form, once it's extensive, we can tell that it's blood vessel. But at the very early start of the development of the calcifications, sometimes it can be confused with early breast cancer.
So what are some of the biggest myths about breast cancer that keep women from getting checkups? You know, we have all kind of myths in our community about things, especially cancer. When the air hits it, it's going to spread, or this happened to my uncle. I mean, what are some of the myths about breast cancer?
So one thing, some people are afraid of the radiation, but the radiation dose is very, very low, and it does not cause breast cancer. So some people think if they get a mammogram, it's going to cause breast cancer, but it doesn't. The other thing is that some people think that they don't have any family history of breast cancer, so they can't get breast cancer. And so that's not true. Most people who develop breast cancer, they do not have a family history of breast cancer. So those are two of the main myths that I'm aware of.
Do you experience any mistrust in the breast cancer detection arena? I mean, you know, everybody can fear the system to some degree. Do you see any things in particularly that you've noticed that represent a mistrust on the part of females concerning breast cancer and getting screened, or getting biopsied, or getting treatment? I mean, are those barriers or hurdles still there to a great degree?
Yes, they are, and sometimes the mistrust is warranted, but some people just don't think that the mammogram is useful. They think the doctors are just trying to make money, you know, but that's not true. It has been proven that screening mammograms save lives, and it's very important for women to get screened.
So we're in this insurance circus surrounding healthcare, and everybody's concerned about costs. What options are there for affordability of mammograms and people who may be financially challenged or don't have any insurance at all?
Okay. So people that have insurance, because of Obamacare, the Affordable Care Act, all insurances pay for screening mammograms, okay? But if a person doesn't have insurance, then they may qualify to get the screening and diagnostic workup done through the Breast and Cervical Cancer Control Program, so the BCCCP. And you don't have to be poor in order to qualify. Your annual income has to be less than 250% of the poverty level. Okay, so you can have a decent income and still qualify, even if you're underinsured. So some people have insurance, but maybe they have a high deductible. They may qualify to be helped with the BCCCP program, or if they don't have insurance at all, then they also will qualify.
We are now trying to influence communities to actually take a step up, buy into their own care as far as health is concerned. Tell us about the mobile breast cancer unit that you're intimately involved with at the University of Michigan.
Okay. So the mobile mammography unit, they have the same equipment. So some people think if they go to a mobile unit, they're getting suboptimal care. But they have the latest equipment on the mobile bus. They have the same technologists that examine the patients at the hospital and at other clinics, and the same doctors read the exams. But they take the bus to the community, so it'll be easier and more convenient for patients to get serviced. They may come to rural areas that don't have easy access to mammography units. They can go to clinics. So if your clinic would like the unit to come, they can just call or contact University of Michigan and apply and request the unit to come. And so it is useful. It comes on the weekends. It can come on the weekends. So it can be available at times when patients may not be able to go to a regular clinic during regular business hours.
So the only difference is location. So that means that there are all alternatives in terms of how people can get screened. Do we still recommend self-breast examination to females?
No.
Why did that change?
So what is recommended that women are aware of their breasts. So they have to examine themselves to know, what their breast normally feels like. So they should be aware of how their breasts feel and how their breasts look. And so if they notice any change, then they should report it to their doctor. Now, it has been found that when women detect their own breast cancers, it's not during a breast self-examination. Okay, they notice it when they're showering, when they're dressing, when they just roll over in the bed. And so it just it hasn't been shown to be helpful as far as detecting breast cancers at an earlier stage. Some people do detect their own breast cancers, but usually it's incidental.
So our community is a church community, a social community, and for a large part, what kind of role can these kinds of groups, like the links that you're involved in, what kind of role do they play in terms of awareness of breast cancer?
Okay. So they can have healthcare providers come and talk to their members and inform them about the screening recommendations, when they should be screened, if they have family history of premenopausal breast cancer, They should know that that's something that they, should report to their doctor so they know whether they need to be screened earlier. So these organizations can be helpful in educating their members, and also to just encourage them and to let them know that breast cancer is not a death sentence. Mm-hmm. Most people who are diagnosed with breast cancer, they live normal lives. Mm-hmm. But some people still die, and as you mentioned earlier, it's more, black women have a higher death rate than white women from breast cancer. But still, most women, including black women, they live normal lives after the breast cancer diagnosis. But we don't want one woman to die from breast cancer. So that's why it's important to spread the news and to educate the patients.
Last question. Research and clinical trials are very important in all aspects of medicine. How are we doing in terms of recruiting African Americans to clinical trials in breast cancer treatment?
Not very well, okay, but we want to encourage, like that's another thing that
it's part of the education.
Yes, that the churches and the different organizations can encourage their patients to participate. And it is very important because these clinical trials come up with cancer treatments that can be, really life-saving. Things that hadn't been used in the past, and we'll be able to know whether it works on the majority of black women if black people participate. And so it's very important for the word to get out that people should participate in these clinical trials.
Right. We shouldn't have any repeats of the tamoxifen story in this history of this country going forward, especially with the availability of clinical trials. Annette, thank you for joining us today. It's certainly been a pleasure.
Thank you for having me.
Our guest today has been Dr. Annette Joe, Clinical Associate Professor of Radiology at the University of Michigan Medical School and a Fellow of the American College of Radiology. As we have mentioned throughout the show, when it comes to breast cancer, early detection is key. Screening saves lives. For Primary Care, I'm Dr. Lonnie Joe.